This is Michael Smith of MedPage Today. I'm in Vienna at the International AIDS Conference. The issue of how many people actually have HIV remains a rather vexed question. In the United States, the CDC has recommended, since 2006, that regular routine opt-out HIV testing should be part of medical care. I'm speaking with Dr. Bernie Branson of the CDC, who was lead author on those 2006 recommendations. Dr. Branson, welcome to MedPage.
Thank you.
Let's begin with the issue of routine testing. Why routine testing as opposed to looking for HIV in places we know where it is?
We've been looking for HIV in people who are at high risk for a number of years, and we have reached pretty much the limit of what we can accomplish. Approximately 79% of people who have HIV have been diagnosed. Finding the other 21% has been difficult. In several studies where we've screened a large number of people, about half of those who turned out to be HIV infected had no risk factors, nor did they have a diagnosis that would have prompted an HIV test. So the only way to find them is to do screening.
Okay, so this routine screening, the idea is instead of people asking to be tested, they would be routinely tested unless they say, I don't want to be tested.
Indeed, and the part of the problem is that the people who did get diagnosed tended to get tested because they were already sick. So they had been ill with HIV, or at least harbored HIV, for 10 years before they developed these symptoms. And so the proportion of people who were diagnosed late in the course of their disease was really way too high.
I see. Now, we saw a report this week in the Journal of the American Medical Association from an emergency department in Denver, and they found that they were only getting about a quarter of their patients actually agreeing to be tested. They would in fact opt out. Is that typical, or do we see better results elsewhere?
It's actually pretty unusual. There's a big range of other results. In most other studies, the proportion of people who accept testing is in the range of 60%. One of the things this report didn't talk about is why people opted out. And in other studies, when they've done those interviews, the most common reason for people to choose not to get tested is that they'd already been tested. And so part of the interpretation of these kind of figures does require understanding why people said, not today.
What about individual docs or physicians in private practice? This is an emergency ward. Are you seeing any kind of uptake? I know the professional societies are all on side with this, but are the doctors themselves promoting testing?
We're seeing an incremental change with doctors advocating testing for their patients. What tends to happen is that when people begin recommending HIV testing and then they find an HIV positive patient that they weren't expecting, it causes much more rapid adoption in those circumstances. It's much easier for doctors in practice because they are ordering a lot of routine screening tests for individuals when they come through, and so just adding one to the list when other blood is being drawn is really what we're suggesting and what more of them are beginning to do.
Mm-hmm. Can you put some numbers on that? Can you quantify it at all?
Well, the metric that we're using to mark as progress is that the National Health Interview Survey has been conducted since 1984 and asks people if they've ever been tested for HIV infection. Between 2002 and 2006, the proportion of people who said, yes, I've been tested, got stuck at around 40%. It had stabilized. That represents about 71 million people. Since that time, since 2006, it has increased each year so that now 11.5 million more people have been tested, and so we clearly think it's making a difference to recommend routine testing.
I see. Clearly there are barriers to this. Can you sort of quantify what would delay any kind of uptake?
The largest barrier is that, in fact, at the time the recommendations were published in 2006, 20 states in the United States had explicit laws requiring written informed consent before an HIV test. Most providers consider that process of written informed consent to be time-consuming and a barrier, and was one reason they cited for not testing. Since that time, 15 out of those 20 states, including large states like California, Illinois, Washington, D.C., have changed their legislation, and most recently in New York State, the legislature has passed it, although it's not yet signed by the governor. And so those barriers are changing, and it really facilitates the process for physicians. But also when the legislation changes, people notice, they pay attention, and I think induces them to actually act on this since there's been a change in their environment, in their state.
What about the cost element? I know in this study in Denver, they found that the difference between their routine testing and the testing based on risk factors was quite marked.
Well, I'm glad that you raised the point, because when you talk about the cost element, a lot of it has to do with which test you use. In the Denver study, they were using the point-of-care rapid tests, unlike the usual thing a physician will do in his office, which is send it off to a laboratory with other testing. In another actual emergency department study in Houston, they had started doing these point-of-care rapid tests with individuals, and it was costing them, with personnel and testing costs, about $75 a test. And when they switched to the routine method of sending it off for the conventional EIA, that cost went down to $12 per test. And so the issue is not only how many people you test, but what kind of test you do and how those costs build together. The key ingredient is that taking care of a person who has HIV infection, lifetime costs are pretty expensive, and you don't need to prevent very many cases before you recover all the costs of a screening program.
I see. Where do we go from here? Just wait and see and hope it gets better, or keep pushing it? Or what are you doing at CDC?
I think we're learning from our experience. Part of CDC's recommendation indicated that people should initiate screening, and if they didn't identify at least one case per 1,000 people screened, then it wasn't warranted to continue screening. The idea is not just to do this mindlessly forever. As I mentioned, many providers have found patients with HIV where they didn't expect it. Other providers in very low prevalence areas have not found patients. The American College of Physicians, for example, says that in order to find out whether or not your rate is 1 per 1,000 or higher, you really have to screen 4,000 people, because you may not find it in the first group that you find. But that is where we're going next, is trying to use the information from screening to figure out how to best focus our efforts in the future.
I see. Well, Dr. Branson, thank you. It's a challenging topic.
Thank you. I appreciate being here.
In Vienna, I'm Michael Smith, MedPage Today.